So we're going to walk you through our procedures today. We ended up having two procedures today. One had to get rescheduled. Our first procedure was a patient who has been suffering with some chronic back pain for quite some time. Now, the really interesting thing about her case is that she has had a lot of different regenerative injection procedures for her low back. Some have helped, but nothing has ever really fully addressed her pain. And she is still, despite having facet joint injections with PRP, with bone marrow, she's had intradiscal injections with bone marrow. Despite having all these things, she's still suffering with back pain and is still kind of in a little flare. And so through our physical exam and our evaluation, and then also her imaging, some of the things that came up for us were some structures that had never been addressed before in her, which is always nice to see, when we have a patient who has had procedures and our physical exam shows us that certain structures that have never been treated before, maybe because they hadn't been properly evaluated, are causing some pain, because that gives us a new avenue to go down to see if that is contributing to her pain. And so those structures specifically were the supraspinous and the interspinous ligaments. Those are the ligaments that are going to basically provide support for that posterior aspect of the spine to prevent excessive forward flexion. And so with that, we can have pain from the actual ligament. But interestingly, we can also have pain from the medial cutaneous branch of the dorsal rami, which is a nerve that we treat really, really frequently for facet-mediated pain. But in this particular case, a part of that medial branch actually comes up and innervates just around the actual spinous process. And so when we have tenderness palpation over the spinous processes, we can also have pain coming from those nerves. And in her case, she'd had a positive response to what's called a medial branch block, which is where they use a local anesthetic. They numb up that medial branch near the facet joint, and it's part of the diagnostic criteria for diagnosing facet-mediated pain before doing a radiofrequency ablation. She had a positive response to that in the past, but not really a strong positive response to the facet joint injections. And so my thinking is that one of the potential reasons that she got improvement was because the medial branch is also going to innervate the supraspinous ligament, the interspinous ligament, and the skin over that area. And so she might have seen an improvement from that, and then not an improvement from the facet joints because her pain was not coming from the facet joint. So today we obviously injected the supraspinous ligament, the interspinous ligament. We also did, she might have some mild discogenic pain. That part's a little unclear still. Now, physical exam didn't really show that, but it kind of fits in with some other features of her pain. And then on imaging and physical exam, there were some mild signs for maybe some nerve impingement in the lumbosacral region. And so we ended up doing a caudal epidural for that as well with our platelet pore plasma. And then we did two fascial plane hydrodissections. One is the lumbar erector spinae plane hydrodissection, which we've talked about before, but basically deep to the erector spinae group and superficial to the transverse process. We inject in that fascial plane, which is going to bathe the dorsal root ganglia and some of those nerves that are coming off the spinal cord there, from the nerve roots, I should say. And the other was a supraspinous plane hydrodissection, which we introduced probably about 3 or 4 months ago with another complicated case that we had for supraspinous and interspinous ligament pain. And essentially what we have there is we hydrodissect the supraspinous ligament from the actual deep fascia. And so we found that is beneficial to help patients in their healing.